So the definitions now around if you have biological complications around implants, we have this one, which is now the peri-implant mucositis. We see its redness and swelling of the mucosa. We have bleeding on probing, and we have no bone loss. So this was defined in 2008 at the 6th European Workshop of Periodontology. And if we now look at the periimplantitis one, we see that periimplantitis, this mucosal lesion, which is basically the same as we saw in peri-implant mucositis, meaning that it's bleeding. You have an inflammatory response like this. You can also have pus in many instances, but it is always, presence of bone loss around this. So in periimplantitis, you always see bone loss. There are differences between, what different material used. This is periimplantitis around, a Brånemark implant, while this is around those older hollow screw implants by Straumann. I'm just highlighting this because if we get periimplantitis around these type of implants, in my mind, it is not possible to treat those, because when you are down here to the first hole, you will get the bacteria even inside the screw, and it's like a swimming pool for them, and it is completely impossible for us as clinicians to treat. So these type of situations, when it happens like this, they have to be removed, while these ones could possibly be treated. And now coming back to the soft tissue reactions. This is from one early study from the 90s by the group in Göteborg from Tord Berglund and Jan Linde, where they looked at the soft tissue reactions of de novo plaque formation at implants and teeth. And it's an experimental study in the dogs. So what they did, they have dogs with teeth and implants, and they will now compare what happens around teeth and what happens around the implants. And after plaque accumulation, they find exactly what I told you, that the soft tissue response to the plaque formation is that you will have a formation of an inflammatory reaction, both around teeth and around implants. They found that the fibroblast density around the gingival lesion is higher than they are around the peri-implant lesions. And they also find that the lesions around implants are greater than the ones around teeth. So you have a more pronounced infection around the implant than you have around the teeth. And here they concluded in this one, it's in the same year, 92, but with different order of the author, where they have an experimental breakdown of peri-implant and periodontal tissues. They are now going further. And the way they do it, they put one of those cotton threads around the implant and around the teeth. They push them down, and they allow plaque accumulation, and then they push them a little bit further down. And by that, they create an experimental form of both periodontitis and an experimental form of periimplantitis. And when they now compare what is happening around teeth and implants, they see that the disease around the implant is more pronounced than what it is around teeth. I mean, the lesion is bigger than it is, and also the lesion progresses all the way down to the bone level around the implants. So there are very big differences on how it looks when you have peri-implantitis. The situation is quite similar if you look at peri-implant mucositis. Between peri-implant mucositis and gingivitis, the lesions are quite similar. But if we look at periodontitis and peri-implantitis, the lesions are completely different. And this is another study from another Swedish group from Stockholm with Margareta Hultin as first author. They examined 17 patients with periimplantitis and 90 with stable marginal conditions around the implants. And what they looked at in this study was the presence of elastase and lactoferrin. And what they found in this study is that in periimplantitis patients, they found higher concentrations of lactoferrin and higher concentrations of elastase and elastase activity. And this means that maybe if you have more elastase, it is an indication that this might be a more acute inflammatory response than what we would see more in the chronic way of periodontitis. Periodontitis may be more a chronic disease, and this may have more of acute type of lesion. And now this also has an importance for us when we are going to examine the patients, because there are now two different entities, the periodontitis and the periimplantitis. And if there is not an encapsulation around this implant, then when you probe, you may probe a little bit further. So summing up here, you can say that periimplantitis is not encapsulated. It extends all the way down to the bone level. You will find in the lesion numerous of PMN cells, and you will also find microorganisms within the infected connective tissue. So this is periimplantitis. For you as clinicians, this is important now when we are going to do the diagnosis, because around a tooth, you know very well that you can have a normal bone level on one side, and you can have here on the other side a deep intraosseous lesion. And this is not uncommon at all. But if we look at implants, you will see that you will have the same amount of bone loss on the whole circumference of the implant. So if you have lost 6 threads or 4 millimeters on the mesial surface, you will have lost 4 millimeters on the buccal and on the lingual and on the distal, because the disease is completely different. Around the implant, it's a circumferential disease. So for you now as clinicians, when you are going to treat the patients, it is important that you will be able to reach the full 360 degrees around the implant. We need to be able to reach all the surfaces around the implant. And this is also shown in this study by Isidore et al., where they made an experimental periimplantitis situation, and they find exactly what I told you, that you will have a circumferential disease. So how do we now diagnose periimplantitis? First of all, we have to do a clinical examination with, and this includes, of course, periodontal probing. It includes that we take a radiograph, and sometimes, if we are not certain, we may use some kind of laboratory examination. Now we are into diagnosis. One of the things that we see quite often around implants is that there are fistulas, like in this situation where the clinician had placed one extra implant that he decided that he wouldn't use. And of course, in such situation, it's not so seldom that you will find that you will have an infection around this implant. And if they are so close to another one, there is an obvious risk that you will have a disease that will encompass both of those implants. So a diagnosis is important to find the fistulas like this. This is a case where you do not have so much covering of the buccal area of the implant, but still we have a fistula, we have a thin mucosa, and we have this quite deep defect around the implant. Fistulas could be dealt with in different situations, like this one here where you have a fistula. We take off the superstructure. You can see it very easily like that. One option for us to handle is, after cleaning now the area, we can go in the palate and take some soft tissue, like a connective tissue graft. So this little piece of connective tissue here, this is the lid, and this is the connective tissue graft that we then can place around the area like this. This is to show you how it looked before. Now we place this connective tissue graft in this area to increase the thickness of the soft tissue, and then following the healing, you can see a very nice healing here after this type of therapy. Another thing that is common when you have periimplantitis is that you get hyperplasia around the implant like this. And hyperplasia is either a small one like this. If it's not treated and if it's there for a long period of time, it could look like this. This is a gentleman, and the interesting thing is that he has no problems. There is no pain. There is nothing like that. He doesn't, observe that he has a problem. Everything is stable. He has this hyperplasia. The pus is coming out of the pockets, so he has no problems. He was recalled to our clinic 5 years after the implants had been placed, and this is the way he looked. So of course he has a huge problem, but he is not capable of finding it. So it's up to us as dentists really to find those clinical situations. And then one way of doing it is to use the probe. I know from the beginning, at least in Sweden, there were, some dentists and prosthodontists that said it is not, advisable to probe around implants. And of course, this was wrong. We need to probe. Now, the question is, are we going to use a metal probe or a plastic probe? I think it's up to you as clinicians to decide. I just, with this picture, want to show you that there is a difference if we use the plastic one or if we use the metal one. You will go in the same clinical situation, you will get completely different readings. So one absolute important thing is to always use the same probe. Otherwise, you will have a difference of maybe 2 millimeters between measurements just by changing the probe. So whatever you do, use the same one. For me, I think it's more easy to use the plastic probes around implants because they are a little bit flexible, so it is possible for us even to reach areas where you need some curve on the probe. So for me, I prefer to use the plastic probes and thin plastic probes. Basically the one we are using in the clinic at present is this one. It's a U3D probe, and I think it's thin, it's nice to use, and the contrast between the yellow and the black is very good, and you can change the tip of the probe, so you don't have to buy a new one the whole time. You can just change the tip when you feel that it's necessary to do so. So what happens if we probe? So this is a study by a good friend of mine in Denmark, Søren Skov, on monkeys, where he had implants in the monkeys, and he had healthy peri-implant mucosa, mild mucositis, gingivitis. He had severe mucositis, gingivitis, and periimplantitis, periodontitis. And these are from his study. You can see in the healthy situation, with the implant. This is here, there, and there you have the probe. And this is the probe tip, and this is now where you have the bone level. This is the healthy situation around the tooth, where you have the probe tip and you have the bone. Now we go to the periimplantitis and to the periodontitis areas, and he does the same thing. He uses the probe, and you can see what happens in periimplantitis area. He probes almost all the way down to the bone level, whereas when he is probing in the periodontitis site, there still is some soft tissue between the bone and the probe tip. So there are absolutely differences in when you probe around implants and teeth. Probably now this is, as we discussed before, dependent on that the infection looks different around implants than it does around teeth. So then it is important, of course, to understand that it is possible to probe, that we do not damage the things. And here is one of the studies that has shown that it will heal quite soon after probing. It's a study from 2002 with Etter as first author. They had 3 dogs, 3 fox dogs. They extracted the premolars. They allowed healing for 3 months. They put implants in each quadrant of the dogs, and they used the probe 3 months later. This means after healing. They had a 0.45 millimeter probe, and they used a pressure of 0.2 newtons. And then they obtained block biopsies, as you can see, to have data from 1, 2, 3, 5, and 7 days after probing, just to see how the area heals after this situation. This is from the study, taken pictures from the study with the probe in place. And this is now where you can see, you have the probe has been here, and now it is closing up like this after only a few days. So what they concluded is that the probe, of course, causes a separation between the implant and the epithelium. This is when you probe. They found that the probe tip was located as the most coronal level of the connective tissue, and already after 5 days, this was completely healed. So with this, we can say that it seems to be, no problem to use the probe. It heals, you can use it, you should use it. This is the only way for us really to diagnose the presence of periimplantitis. They also, in this study, reported that absence of bleeding on probing was a good indicator of a healthy situation. And this is the same thing as we can say around teeth. It's difficult to say that it's really a disease when you have bleeding, but if you do not have bleeding, this is a healthy situation. They also showed, and which is important for you, that probing depth at implants may be influenced by the system used. So for us in the clinic, this means that really what we should do is to probe after we do put the superstructure in place, to have some kind of reference value. Because we know that in some situation, for example, in the upper area, in the upper aesthetic area, we may place the implants quite high up, so we will end up maybe with a probing depth of 5 to 6 millimeter as the normal one. But we need to know that this was there from the beginning, so that we can relate any changes to what we had when we really placed the implants in this area. Recently, this study on probing was published by the group of Serino and Turi. This is together with Klaus Lang as well. And this is very interesting for you in the clinic. Because what they did, they had 89 implants with periimplantitis. They probed before and after they removed the superstructure. And then they made a flap and they measured down to the bone level. And then they related all those measurements to each other. And this is just from their paper. You can see they were probing with the superstructure in place, without the superstructure, and during the surgical procedure. What they found was that in 37% only you had similar depth with and without the superstructure in place. So when we have the superstructure, it is more difficult to probe. This is really what we can demonstrate. In 24%, I mean almost 1/4 of the cases, the difference between those probing was more or equal to 2 millimeters. But when they removed the superstructure and they probed, they found a very high correlation between those probings and the probings done during the surgical procedure. And then the fourth bullet point for us is important, because it says that in 66% of the cases they had similar probing depths on all 4 sites around the implant. And for us in the clinic, this is very important, because sometimes you end up having, these type of patients. And how could you probe in this case? It is completely impossible to probe. And if we cannot probe, how could the patient in such a situation do any cleaning? Of course they cannot. So then we just have to wait until we have huge problems. If we go to probing, this is another case where it is not possible to probe on the buccal surface at all. But of course we can now probe here on the mesial and distal surfaces and also on the lingual surfaces. And going back to the study by Serino, then we know that those measurements that we are taking here would be fairly, representative of any buccal measurements we would be able to take on this implant. So this is the good thing, that the destruction is the same all around, so the probing will be almost the same. That's the good thing. The bad thing is that we have to treat 360 degrees around the implants, which is more difficult. So that's the bad thing. After probing, we should look for bleeding, and we should look also for presence of pus. And when we talk about bleeding, this is a profuse bleeding like this, and here you can definitely see pus coming out from the sulci. When we are taking radiographs, try to align them in a way that we can see the threads of the implants, because if we don't align them in the correct way, it's difficult to see what is really there. And this, you see, we can anticipate there is something wrong here and something wrong there. But when you take a real nice radiograph, you can see that there is really a gap here, and you can see the periimplantitis lesion more prominently like that. The same here. You can really think, yes, there is something that is not correct. In this way, you can see it much better. So radiographs are more difficult to analyze around implants really than around teeth. And this could be demonstrated also in this case, where the radiograph looks fairly good. But when we did the probing around this implant, we had some deep probing depths. And it was decided to make a surgical procedure. When we do the surgical procedure, we will find in this case that we have a circumferential defect like this. On the buccal, the defect comes down here. Then you see that this implant is placed in a very buccal position. So this is not periimplantitis, this is a dehiscence, but periimplantitis is up in this area and also goes all the way around on the lingual. Radiographic impressions that could look also like periimplantitis, are when you have, this is a case where you have a fracture of the implant. So when this superstructure was removed, you could also remove the upper part of the implant. And I will show you another case like this, where you have deep probing depths, you have periimplantitis-like defects in the upper. When we remove the superstructure, you see that there are fractures on both of those implants. So when you have fractures, you may have a similar situation. It looks like you have a true periimplantitis case. And then we are very lucky that we can remove the superstructure and see what is really the problem. So in order to be more precise in how to diagnose periimplantitis, it is for sure an advantage if we can have a radiograph from the time where we put the superstructure in place, and then we can relate any changes in the future to what happens compared to that type of radiograph. And when you have any changes in clinical parameters around the implants, I think there is an indication to take a new radiograph to evaluate eventual bone loss. So you will see maybe a case that could look like this before, and after. I mean, here you see there are some bone loss, but this may also be due to the healing. And then you get deeper pockets, you take a new radiograph, and you see that compared to that, we have lost considerably amounts of bone around the implant. If we don't treat it, the disease can be extremely advanced, like in these cases where you see the defect is going almost all the way down to the apical part of the implant in both those situations. And of course there are those clinical situations where you have the end. I mean, you reach really where you have to remove the implant. And these are, of course, non-treatable. But now, please, look not only at the implants, look at the teeth, look at the type of therapy that is performed. I mean, we have a periodontal defect here, we have carious lesions here, we have a period defect here, we have a huge defect, around the implants. So this is really the final stage where we have to remove the implant as such.